أسعد الله مساكم، أهلا بكم في هذه الأمسية، وهي تقديم حالة من الدكتور قاسم الريماوي، اختصاصي الطب النفسي في المركز الوطني للصحة النفسية في الأردن. الدكتور قاسم من الاختصاصيين الشبان النشيطين الواعدين. تفضل دكتور قاسم.
مساء الخير جميعا، وشكرا دكتور وليد على التقدمة، وبشكرك انك اعطيتنا هاي الفرصة. اليوم راح يكون في عندنا كيس برزنتيشن، وانا هاي الكيس اخترتها من عدة كيسز فكرت فيها، لانه هاي كيس كانت عندي اول مرة راجعني. هو شاب لما كنت سنة اولى او ثانية اقامة، واعتبرتها بالنسبة لي كانت learning opportunity. و I learned from، يعني زي ما بيحكوا from my mistakes more than from my correct judgment. فخلينا نبلش معكم بالكيس برزنتيشن. وأول شيء بدي أبلش بالبيشنت بروفايل. طبعا I kept the name hidden. بالنسبة للبيشنت بروفايل: name MAA, gender male, age 27 years old. He was born on the 30th of December 1996. Marital status: single. Level of education: at the time of the presentation, he was a student in hotel management. He was unemployed, and the place of residence he lived in Irbid. The main source of information was the patient himself. Mr. M.A. visited the clinic for the first time on the 31st of July 2018 alone to the outpatient clinic في المركز الوطني للصحة النفسية. When asked why he didn't bring any family or friends, he stated it's too personal for him. وراح يخبر الناس لما يكون الوقت يحسه مناسب. بالنسبة للتشيف كومبلينت اللي عبر عنها، كانت مزاجي سيء، بدخل بفترات اكتئاب طويلة وما بعرف أطلع منها. لما تعمقت معه شوي بالhistory of presenting illness, the patient explained that he had felt this way for years but to a lesser degree. يعني كان في عنده من سنوات low mood, occasional insomnia and loss of interest. Uh, However, in 2015, unfortunately, he was sexually assaulted by a group of men he used to know in Irbid, and he told me that it was a form of revenge for interpersonal issues between them, and that when the symptoms started to worsen significantly. Since then, he has been sleeping for over 11 hours a day, as compared to an average of 7 to 8 hours, and still feeling unrested and sluggish. He gained a significant amount of weight and spends most of his time at his room isolated from his family. He also stated that he has had thoughts of ending his life or suicide, but has never attempted to. The last time he had such thoughts was 2 days prior to the visit. هلا على كلماته: during the periods of particularly bad day، يعني هو حكى لي الأيام السيئة أو المتعبة. He hears an unrecognized male voice whispering his own name to him. He also stated that during those times, he strongly believes people are talking about him and laughing at him behind his back, even those who are complete strangers. كمان the patient stated that he بعض الأحيان، يعني كان كلامه أحيان مش كثيرة، he feels high, hyperactive, and على كلماته برضه slightly narcissistic. حكى لي نرجسي شوي، بحس حالي كنت. And as if he does not need to sleep at all, only sleeping about 3 to 4, an average of 3 to 4 hours per night. He also during these periods, he tends to drive above the legal speed limits, unlike his usual. هو عادة سائق هادي. He claims that those periods typically only last a few days at most. لما سألته حكى لي على الأغلب حوالي 3 ل4 أيام. He also stated that he feels extremely anxious when he's asked any questions at the university lectures or has to speak in front of people and tries to avoid it. وبرضه بكلماته حتى بصير عنده shaking, heart racing, sweating, and mumbling. آه، حبيت أسأله شوي أكثر عن التروماتيك ايفنت اللي صار معه. ما أعطاني ديتيلز أو ما رضي يعطيني ديتيلز. ولما دخلت معه لأنه خطر لموضوع البي تي اس دي. He denied intrusive memories, flashbacks, or nightmares related to the incidents أو hypervigilance. Upon further inquiry about his relationship with his family, he stated that it has been tense for many years. لما دخلت معه على ال past psychiatric and medical history, he visited a private psychiatric clinic in Irbid في نفس السنة اللي جاني عليها، بس قبل ب6 شهور بشهر 1. And he stated that he did not seek professional help earlier due to social stigma. كان مستحي يروح للدكتور. He was diagnosed as a case عند الطبيب اللي شافه bipolar affective disorder. والدكتور وصف له أدوية، ما قدر يتذكر أسماء الأدوية، بس اللي كان متذكره إنه في واحد منها كان أنتي سايكوتيك والثاني كان دواء للصرع بكلماته. He continued visiting the doctor for 3 months. وحكى لي إنه حس بتحسن متوسط في أول شهر من أخذه للعلاج، بس بعديها استمر على الدواء كمان شهرين، وخلال الشهرين هدول ما كانش في أي تحسن وقطع الميديكيشن. بالنسبة للسبستانسز, the patient admitted to abusing pregabalin 300 ملغ twice or 3 times per week. ولما سألته ليش حكى لي self medication for low mood and anxiety for around مستمر for around 3 years، بس قبل 7 شهور توقف لأنه خاف إنه يدخل في addiction. He denied abusing any other substances and stated that he only drinks alcohol socially. He smokes 1 to 2 packets of cigarettes per day, denied having been arrested or incarcerated before. He also denied having any significant health issues, chronic illnesses, head trauma, or surgical interventions in the past. As for family history, both of his parents are alive. The mother is 59 with no health issues as far as he knows. The father is 67 and he is hypertensive. According to him, there was no known family history of psychiatric illnesses or substance use disorders. ولما سألته أكثر عن the family dynamics and structures, he told me he had 5 siblings in total, 4 sisters and 1 brother, and he is the youngest amongst them. He was brought up by both of his parents at the family home in Irbid. وبناء على وصفه في poor familial communication, he described his parents' relationship as cold. He described his family من ناحية socio-economic status as a low middle class family living in a simple home. His relationship with only one of his sisters is warm, according to him. ولما اجينا على موضوع السكول and work record, MA finished توجيهي at the age of 17 and started the first year of the university at the same year بال 2014. He was generally an average student with no significant issues at school. In university, his academic performance was average at the beginning, بس بعدين started to deteriorate after the incident he described as sexual assault. He had to repeat several classes and was almost expelled from the university due to low GPA, وأجل أكثر من مرة. No work record, and he was unemployed at the time. ولما أخذت منه sexual history, the patient stated that he is bisexual, leaning more towards the other sex. He desires to get married and have children in the future. He also stated that he had a few sexual experiences with both sexes. He also suffered from the mentioned sexual assault 3 years ago in 2015, refused to go into detail about the experience. The pre-morbid personality, he described himself as always having been somewhat a shy, anxious person, not having many friends, with a generally pessimistic view of life, and a relatively frequent engrossment in fantasy thinking. لأنه حكى عن حاله إنه شخص idealistic. He considers himself to be a moral person. He went through many philosophical and religious dilemmas in his life, alternating between belief in the Islamic faith and atheism or agnosticism. He also said that he enjoys owning pets and driving cars. The mental state examination at the first visit, the patient was tidy, clean, with short facial hair, dressed in dark clothing. However, it was appropriate for age, gender, and weather. He was calm, cooperative, but lowering his gaze with only partial eye-to-eye contact. He looked slightly dysphoric and anxious. No abnormal neurological signs or movements could be noted, and no remarkable facial markings or tattoos seen. He stated that he is feeling depressed and tired, still suffering from an increased appetite, and feeling sleepy despite having slept for many hours. His speech was coherent and to the point, with low tone and volume. The patient expressed delusions of reference. He stated that people are still talking about him behind his back and admitted to having active suicidal thoughts at the time with no intent to seriously attempt it. Also, no intrusive thoughts or homicidal ideation was noted. He denied any abnormal perceptual disturbances at the current time. He was oriented to time, place, and persons. Attention and concentration were normal. Immediate, short-term, and long-term memory were also all intact, and his intelligence was within the normal range. Test judgment was intact. However, the patient was partially insightful towards his condition. He understands that he has an illness of a mental nature in need for treatment, but unsure of what it is, and blames his parents for the condition. وبضل يحكي إنه أهلي اللي وصلوني لهاي المرحلة. فكان الديفرنشال تبعي وقتها as an unexperienced resident, bipolar affective disorder 2, current depressive episode with psychotic features, substance-induced bipolar disorder, schizoaffective disorder, وضفت عليهم البوست traumatic stress disorder and social anxiety disorder. Provisional diagnosis was eventually, after many visits, was bipolar 1 disorder with rapid cycling. Management, the patient was offered admission but refused as it interferes with his education. Routine lab tests were ordered, and the following medications have been prescribed: olanzapine, 5 milligrams twice daily, and valproic acid with sodium valproate or dipiquine 500 milligrams twice daily. Also, cognitive behavioral therapy in the Irbid clinic was recommended as the patient was residing in Irbid at the time. هلا بدي أدخل على الفيزيتس تبعونا، وهي يعني it's a long history starting from 2018 and ending about 4 years later. First visit was in September 2018. The patient came to the clinic 6 weeks after the initial visit. تأخر شوي. He was seen by another colleague as I was not available. هاي مشكلة عندنا مرات تصير بالمركز الوطني للصحة النفسية. According to the notes اللي سجلها زميلي, he complained of easy irritability, still sensing that people are talking about him behind his back, and low mood accompanied with increased sleep and appetite most of the time. He denied any perceptual disturbances, and there were no changes in the anxiety symptoms he described earlier. Olanzapine dose was increased to half a tablet, 10 milligrams, half a tablet in the morning, 1 in the evening, and sodium valproate, valproic acid was increased to 1+2, sorry about the mistake, and he was also given citalopram, 40 milligrams, half a tablet a day. We are limited in the doses in the National Center for Mental Health. Second visit, he came to the clinic 2 weeks later, as scheduled. He stated there is around 40% improvement in mood, slight improvement in the symptoms of social anxiety, which are most prominent in university lectures. The dose of citalopram was increased to 40 milligrams once daily, and there were no changes in the other medications. But the patient has not started CBT procrastination. He also has this problem of delaying his obligations. In the third visit, October 2018, there was a significant deterioration in mood and anxiety symptoms. He stated that he returned to the same levels of depression as the initial visit, denied any unusual life stressors or interpersonal issues, any new unusual life stressors or interpersonal issues, no psychotic symptoms, manic or hypomanic symptoms reported. He was compliant on the medication. So citalopram was discontinued and he was started with fluoxetine 20 milligrams once daily in the morning. He also has not started CBT yet, who admitted he has some ambivalence about its usefulness and the problem with talking in detail about the traumatic experience he went through. Psychoeducation was provided and he asked for some time to think about it. For the next 3 visits, 3 months, the mood and anxiety symptoms improved around 50 to 60% according to subjective experience. No psychotic symptoms, mania or hypomania reported. Now we go to 2019, January 2019. He visited the clinic with the following complaints: depressed mood most of the time, slightly better than the initial visit. Anxiety symptoms return as he described them the first visit. And he also complained of excessive daydreaming, which is more than usual, his usual. Again, the patient denied any unusual or new life stressors or issues. He also denied non-adherence. When he finally started CBT, he only took 1 session thus far. So the medications were changed to, and I took a risk again with fluoxetine, 20 milligrams, increased to 2 tablets. Other medications were unchanged. For the next 5 weeks, the symptoms of depression and anxiety improved, but unfortunately deteriorated once again. He was asked in detail about all the other possible physical symptoms, and he complained of cold tolerance more than he's used to. So at this time, I ordered thyroid function tests. In the next visit, the patient reported subjective improvement in mood and anxiety symptoms, around 40% improvement. No psychotic, manic, or hypomanic symptoms reported. Thyroid function tests were all within the normal limits. There was improvement, but unfortunately, it only persisted for around 3 months. In June 2019, the patient visited again with the same complaint of low mood, increased appetite and sleep, poor concentration, and subsequently poor academic performance, but this time with a 4-day long episode of high mood, in his words, hyperactivity, increased confidence more than the usual, and excessive spending. He spent more than he could afford. The patient attended weekly CBT sessions by that time, 12 sessions, claims they were ineffective for mood symptoms. However, they seem to be helping with his social anxiety. He stopped the sessions after discussing the situation with the psychotherapist. So I changed the medications again. Fluoxetine was discontinued, and I started him on a lamotrigine schedule from 25 milligrams to 100 milligrams in the course of about 6 weeks. And he was still taking sodium valproate, valproic acid, propivacaine chrono, BID, 500 milligrams, and olanzapine, 15 milligrams divided. In the next visit, which was 6 weeks later, there was notable improvement in affective symptoms. His mood stabilized with no depressive, psychotic, manic, or hypomanic symptoms. But the patient wishes to discontinue olanzapine. He gains a significant amount of weight since starting about 10 to 11 kilograms of weight, despite watching his food consumption. Olanzapine was discontinued and he was given quetiapine, 200 milligram, twice a day, gradual up titration. Other medications were unchanged, and he stabilized, but again, unfortunately, only for about 2.5 months. In November 2019, the patient discontinued all medications due to weight gain. He claims that he lost about 6 kilograms in about 6 weeks since stopping the medications. This visit he attended with his sister, and this was the first time he attended with someone. Symptoms of depression reported by the patient's subjective experience. His sister reported social isolation and indecisiveness. She also reported that there was a 1 week period of her brother being excessively talkative, hyperactive, almost getting into car accidents due to reckless driving, and showing grandiose attitude. His sister suggested admitting him to the hospital to her parents during that period, but his parents completely refused. During the visit, no manic symptoms are noticed. The patient looked dysphoric and anxious. I offered aripiprazole, which is not available in the National Center for Mental Health, and it was discussed as an option, but unfortunately, the price of the medication was a barrier to the patient. Measures to lose weight while taking the medications were discussed. However, the patient clearly expressed his refusal to take the medications anymore. He also complained of the return of symptoms of social anxiety, although less than before. So I opted to start him on lithium carbonate. Was suggested, I discussed it with the patient, and with him and his sister. He was educated about the necessary investigations needed and the possible side effects, including weight gain, which was an issue for him. Lithium carbonate, 400 milligrams once daily was given, and serum lithium level was 0.6 milliequivalent per liter 1 week. After starting the medication, the dose was increased to twice daily. The lithium levels rose to 1.0 milliequivalent per liter 1 week later. I also added lorazepam 0.5 milligram to be discontinued in 2 weeks. We come to August 2020. The patient continued the medication since the last visit for 6 months and claimed he was relatively stable during that period and then deteriorated to the previous level despite being compliant with the medication. صار عنده multiple depressive episodes alternating with manic episodes, elevated mood, prominent delusions of grandiosity. كان عنده فكرة إنه he is the most skillful person in all of Jordan in everything. Reckless driving, overspending, irritability, and hyperactivity. According to the patient's account, the depressive and manic episodes usually occurred at the time 3 to 4 days apart. وأحيانا حكى لي إنه ممكن يصيروا كمان بنفس اليوم يكون بس ساعات. His academic performance suffers. He denied again any unusual stressors or interpersonal issues. Adjusting the dose of lithium was discussed with the patient. He again refused. After consulting at the time with the senior psychiatrist in the clinic and discussion with the patient, the following medications were prescribed: carbamazepine, 200 milligrams twice daily, to be increased to 400 milligrams twice daily in 5 days, and risperidone, 4 milligrams once daily. In March 2021, the patient has been stable for the past 6 months, but for the past month, he complained of poor sleep, about 3 hours of sleep per night, poor appetite, and low mood most of the week. No manic, hypomanic, or psychotic episodes reported, and no suicidal ideation also. He denied any unusual stressors. Carbamazepine was increased to 3 times a day, so 1200 في اليوم, and risperidone 4 milligrams twice daily. In June 2021, the patient has been stable for the past 2.5 months, with some improvement in academic performance. For the last 2 weeks, the patient complained of low mood, poor concentration and appetite, and decreased level of activity, but less than before, slightly less than before. Medication changes, risperidone or carbamazepine the same, and then mirtazapine was added, started half a tablet at bedtime, increased to 1 tablet after 2 weeks. In July 2021, the patient was happy to report that he's finally doing better in his studies, sleep, appetite, activity levels, and mood were improved. And he continued visiting the clinic for follow-ups, and to the date آخر زيارة له كانت من حوالي شهر ونص أو شهر. No depressive, manic, hypomanic, or psychotic symptoms reported. And he finally graduated in 2023, reports a significant decline in anxiety symptoms, currently looking for work in his field in Oman. Thank you for your time and attention. Discussion.
شكرا جزيلا دكتور قاسم على هذا التقديم العظيم. يعني تقديم ممتاز، ولكن أنا في بعض التساؤلات من ضمنها يعني your final diagnosis today.
My final diagnosis for today, bipolar affective disorder type 1 with rapid cycling.
How much rapid is it?
At one point about في 2021 كان ultra rapid، كان يصير عنده التشينجز تصير بنفس اليوم أو بينهم يومين ثلاث.
نعم. يعني as an exercise for our resident, how would you formulate this patient? If somebody has just walked in, didn't hear anything, do the formulation, please.
تمام حكيم. هلا البيشنت اللي أنا قدمته مستر A, he was 27 years old at the time of presentation. He's 27 years old today, student on hotel management. The patient presented for the first time in 2018. The chief complaint, he complained إنه حكى مزاجي سيء، بكون بطول، بكون لفترات طويلة سيء. وأيضا كان عنده في مشكلة بالسوشيال انكزايتي خصوصا في المحاضرات، ووصف كمان لنوبات من elevated, slightly elevated mood and low decreased need for sleep for a few days. البيشنت راجعني من 2018 وضل يراجع فيه لحد اليوم لنهاية السنة الماضية تقريبا، وخلال الفترة هذيك كلها مر بتقلبات مزاجية كتير. بلشنا معه في البداية بالميديكيشنز اللي بلشناها كانت بالأولانزابين وبالجيباكين كورونا والصوديوم فالبرويد valproic acid. There was some improvement. Unfortunately, it did not last too long. رفعنا الميديكيشن، برضه ما كانش في أي تحسن. صار في تحسن لفترة مؤقتة، لكن بعد هيك التحسن اختلف. تراجع عنده التحسن. بعديها I changed his medication multiple
This is going
times.
into history, but when you talk about formulation, what do you exactly understand by formulation? What it should include?
Short summary of the case, patient's basic information, differential diagnosis, the provisional diagnosis, the important factors that affected the patient's improvement.
What about the PTSD? Have you excluded PTSD?
Yes, and eventually I excluded PTSD. He has no symptoms of it. The incident he had, the sexual assault, affected his diagnosis, which might have been bipolar 2 if he had not gone through this traumatic experience, but we couldn't know that. So I excluded PTSD, yes. He had no symptoms.
And social phobia?
Social phobia currently improved significantly.
When
his
you said he has bipolar type 2 as a final diagnosis, that means he has no other comorbidity.
Yes, maybe I forgot to mention that. He has social anxiety disorder, which improved with a combination of cognitive behavioral therapy and medication.
How common is anxiety disorders in bipolar disorder?
As far as I know, very common. Sorry, دكتور كأنه الصورة
What
راحت.
what frequency and how prevalent?
بصراحة مش متأكد. يعني أنا مرة قرأت إنه I think إنه الثلث، بس أنا مش متأكد من هذا الرقم.
مهم. لا هم أكثر. الشيء الثاني لاحظت بأنه في كل الميديكيشن 1 by 2 يعني الديباكين من 2017 is being approved إنه ينعطى single dose olanzapine single dose quetiapine single dose and that makes much better compliance.
Yes.
Why do you continue on twice daily?
دكتور أنا يعني
Everyone needs twice daily is Tegretol because it's CR. If you want to use something like Neurotop, which is can be given single daily dose instead of having to take twice daily. But before even Tegretol, you were going on this regimen of two times and then 3 times daily, and I find it very difficult the patient to comply with it.
مظبوط دكتور. هي كانت صدقا هي الموضوع ما كانش عندي على توزيع الميديكيشنز، ولو انها كرونو او يعني extended release، بس لما وصلتها للبيشنت مرتين باليوم it wasn't really a good decision on my part. يعني it was something that we are used to صراحة في ال National Center of Mental Health. ف this is the system I used
Well,
to.
this is not really a good system
Yes, yeah,
to start. If all the patients are given twice daily, this is quite difficult to see very compliant patient.
true.
Another point that very immediately antidepressant was added while because the patient is presenting with depression currently, while lamotrigine was delayed for very late time, lithium was delayed, although lithium and lamotrigine could have been the best choice from the beginning.
Yes.
Even lithium and lamotrigine also are given single dose.
Yes, true. ده المفروض الانتي ديبريسنتس صراحة هي كانت ريسكي ديسيجن. أول زيارة بعد الانيشال انترفيو شافوا زميلي كتب له الانتي ديبريسنت. هو الجول في البداية كان not just for the depressive symptoms بس للسوشيال anxiety، ولو إنه الانتي ديبريسنت usually increase anxiety at the start. I continued فكرة الانتيديبريسنتس. تأخرت فكرة اللاموتروجين والليثيوم honestly because I wanted to just try a trial of antidepressants, maybe because he might have been more likely to comply on them.
What guidelines do you use in using antidepressant in bipolar 1?
عفوا دكتور ما سمعت.
What is the guideline that you adopt in managing bipolar 2 patients with antidepressant?
هلا السيستم اللي بنمشي عليه او الجايد لاينز اللي ممكن نمشي عليها بحالة البايبولر 2 مع الانتي ديبريسنتس. usually لو حسينا أو شفنا إنه كانت ال other first line options ineffective in treating that, or the depression did not improve with it, we might add the antidepressants to the mix while watching possible switching. أنا اللي شجعني إنه أكمل على الانتيديبريسنت في البداية كان إنه ما صار في عنده switching، وكان ما في عنده side effects كتير عليهم، فخلتني أكمل. بس بعدين لما وصلت لمرحلة إنه عم بشوف صار في switching وصار في عندنا risk of mania و hospitalization، دخلت على خلينا نحكي ورجعت للترو أو الريل guidelines.
No. When you noticed that the patient was gaining weight on olanzapine, you switched to quetiapine.
Yes.
How much difference that will usually make, and what other choices do you have?
Yes, هلا the difference is not that significant. بس صراحة we are kind of يعني limited في choice of medications اللي عندنا.
You end up giving him Risperdal, which is available in your center.
Yes, it is available. بس صراحة دكتور ما خطر لي، يعني أنا ما فكرت فيه. I switched to quetiapine. It was the first choice that came to my mind. الريسبيرادون إجا متأخر شوي. وكان في صار ديسكشن على الكيس هاي مع سينيور سايكايترست في العيادة فترتها، ونذكر موضوع الريسبيرادون with تجريتول، فإت واز شوي delayed يعني.
What's the wisdom of changing citalopram to fluoxetine?
honestly لأنه البيشنت لما كان ياخذ السيتالوبرام صار في عنده تحسن عليه. التحسن ما استمر كثير، و I thought maybe switching to another antidepressant in the same class might have a better result, but obviously it did not.
Is there evidence that different SSRI will give different results in depression?
Not always, no.
And what's the risk of giving fluoxetine in bipolar patient apart from any other SSRI?
مشكلة الفلوكسيتين عشان هو اللونج هاف لايف تبعته، فممكن يعمل عنده مشكلة للسويتشنج. وحتى بالبداية كمان في انطرح موضوع الترايسايكليك بس ما مشينا عليه لأنه برضه في عندنا كان high risk of
I want to challenge you that this patient is bipolar 2 and you have made him rapid cycling.
I might have وهاي من الحالات اللي أنا تعلمت منها كثير كويس. بس unfortunately
let us know how would you handle it if this patient, similar patients comes today.
هلا بالوضع الحالي لو هذا البيشنت اجى علي بالوضع الحالي راح ابلش معه على واحد من المود ستابلايزرز، وصراحة كمان على فكرة اللي أنا يعني بعد ما درستها أكثر فكرة المونوثيرابي، يعني بشوف إنه يعني according to Mousley and other resources always start with monotherapy, so I would probably have started them on some mood stabilizer, either something like Dipakine Chrono أو Lanzapine أو Seroquel, and then go on from there. موضوع الانتي ديبريسنتس لو بدي ادخله كان ممكن ادخله متاخر كثير لو حسيت
The patient he presented with depression.
Yes.
Would Dipakine affect depression? Does it help?
As far as I know, it can.
But isn't lamotrigine more effective or in depressed patients in bipolar?
Yes, absolutely. Lamotrigine is more effective, yes. بس هو عشان موضوع كانت عنده الهايبومانيا هيك I opted for I would have opted for Dipakine و honestly Lamotrigine might have been the next option
Why not
for me.
lithium? Now I'm talking not in the past. If you have a patient like this, would you consider him to give him lithium as انسى الأدوية المتوفرة وغير المتوفرة، ألا نفترض أنه كل الأدوية متاحة.
Yes.
وطيب how would you start a patient like this?
I would lithium I would consider lithium تمام. بس لأنه في من الشغلات اللي أنا يعني لما جيت حتى هذا البيشنت لما جيت أعطيه ليثيوم كانت اللي خوفتني من الموضوع لأنه كان في عنده مشكلة كمان أحيانا بالكومبلاينس و doing multiple يعني هو بيحتاج طبعا multiple blood tests مع الليثيوم والتست اللي قبل استخدام الليثيوم، فخفت من استعماله معه. لكن in general if we're talking in general I would say lithium ممكن يكون a very good option خصوصا كمان لأنه في suicidal ideation which is الليثيوم هذا شيء ممكن يساعد فيه كثير في حالات لو البيشنت عنده suicidal ideation. وإيفن حتى يعني بالرابid سايكلينج بالأول كنا نسمع إنه ما بزبط، بعدين قرأت إنه لا you can use lithium with rapid cycling ultra rapid cycling.
نسمع تعليق الدكتور جلال نوفل.
آه، يعطيكم العافية ويسعد مساكم. بالحقيقة أنا يعني شايف إنه في هيك مثل ما كانوا يقولوا في ديول دايجنوزز، في ملامح لشخصية لاضطراب شخصية أو سمات اضطراب شخصية بوردر لاين. بيقول عن حاله إنه هو مثالي، مرات وضعه منيح، في عنده تقلب شديد بالعقائد، يعني إنه مرة متدين، مرة اجونستيك، مرة ملحد. فهذا أمر بالحقيقة بيلفت النظر، ولما بيجتمعوا مع بعض بصير كمان يعني التحسن في يعني في له مشكلة البايسكشواليتي، كمان في نوع من كومبرد يعني هيك كوموربيد مع الاضطرابات القلق واضطرابات المزاج. في عندنا مشكله انه انا ما اعرف تفسيره، لانه احيانا الناس اللي عندهم قلق اجتماعي زائد باحد مراحل القلق، فربما الافكار الملاحقه قد تكون افكار وليست ديليوجن. فتفسيره لهذا الموضوع مهم، انه انت شو شايفه عن جد انه هيك انت كذا، ولا انت خايف، ولا انت متضايق. وخاصه ان احنا في عندنا سيره عندنا سيره سكشوال ابيوز. فأخشى أنه هذول الأشياء يعني ما تم التعامل معهم يعني بشكل كافي، وعنده يعني عنده اتهام بلحظة من اللحظات أنه طبعا هو بيصنف علاقته مع أهله باردة، لكنه بيقول بلحظة من اللحظات أهلي هم السبب. هل فعلا في مشكلة بهذا الموضوع، ولا هو لا جزء من البارانويد اتيتيود تبعه؟ ف يعطيك العافية، يعني التقديم جميل وتفصيلي، لكن أتصور أنه لما بيصير في عندنا سمات لشخصية بوردر لاين أو يعني كلاستر بي، ربما يكون عم بيقول عن حاله هو ايديال وبالتالي بحب التجارب الجديدة، فممكن يكون نروح شوي باتجاه الهيستيريني، وبالتالي هذا بيعطينا تلون آخر لاضطراب البايبولر. هدول الملاحظات بيحكيهم هيك على يعني على الحالة العامة والاستقرار يعني الأخير اللي صار بالحقيقة. هو يعني منيح إنه الواحد يوصل لهذا الاستقرار، بس إذا تم إغفال هذول الأشياء قد يكون في عندنا يعني مخاطر بانتكاسات بطريقة ما. أنا خلصت، شكرا.
شكرا دكتور جلال. دكتور منتصر.
يعطيك العافية دكتور، يعطيك العافية دكتور قاسم.
الله يعافيك.
شكرا على على الطرح الجميل.
الله
أنا
يخليك.
برضه كان عندي نفس يعني هو في ديبريشن، وبلش كان عنده بينام كثير وكان باكل كثير ووزنه زايد، وبلشنا له على اولانزابين وديباكين.
يس.
هاي شوي كانت غريبة كمان. والشغله الثاني بضم صوتي لصوت الدكتور جلال، انه في اشي غريب يعني، هو عن البايسكشواليتي وعلى موضوع الفاميلي، انه كولد بيرنتس بنفس الوقت هم السبب.
مم.
و... فهاي كانت برضو فيها اشي، مش عارف اذا تم الحديث بالموضوع وانتهى خلاص. وثالث اشي هو لما بلش لمترجين، انا شفت مكتوب من 25 بلش، كان
يس.
بياخذ اصلا دباكين.
يس.
فبعرف هاي ماشية مع الجايد لاينز ولا مش ماشية.
خليني أبلش بآخر شيء. هلا الجايد لاينز، هلا أنا اللي بعرفه في موضوع لاموتريجين. you can start 12 12 ونص ملي جرام وبعدين ترفع. بس في as far as I know مثلا زي بماوزلي I think بيحكوا انه انت بامكانك تبلش ب 25 بس يكون التيتريشن slower than usual. تمام، هاي بالنسبة لأول بوينت. وهاي اللي مشيت عليها. هلا الشغلة الثانية، آه كان في سؤال موضوع انه كيف اهله كولد بس هم السبب اللي هم فيه. هلا هم كولد يعني يمكن لو ارجع السلايدز عشان نشوف ال- هم their relationship with each other is cold، بمعنى يعني هو بيلاحظ على اهله علاقتهم مع بعض انه هي باردة بين بعض. يعني آه يعني حتى من ضمن الشغلات اللي حكاها بتحسهم انه مش متجوزين، كانهم بس روميتس. هلا معهم هم كأولادهم هي it's not cold in the meaning يعني هم ما بتعاملوا معهم، ما بيحكوا معهم. علاقته مع أهله كانت كلها مبنية على السلطة. يعني بناء على الكلام اللي حكاه، يعني علاقته مع أبوه إنه أبوه هو الدومينيتنج في البيت، وكل شيء لازم يمشي زي ما هو بيحكي، وإنه سبمسيف، وكان كل شيء ماشي زي ما بده الأب. فبالتالي هو ما كانش حاسس حاله إنه هو بسبورتيف فاميلي. والسؤال كمان كان عن ليش بدينا بأولانزابين وب ديفيكين كرونو. صراحة خلينا نحكي المنطقة اللي أخذتها بهذا الموضوع كانت مبنية على إنه أوكي الديفيكين والأنزابين صحيح إنه بيفتحوا الشهية، بنيموا أكثر، بس مع بعض they could improve symptoms of البايبولار depression. فبالتالي ممكن يبطل ينام كثير أو يبطل. يعني this is the initial thought that I had at that time.
دكتور أسامة.
يعطيك العافية دكتور قاسم، شكرا
الله
جزيلا
يعافيك.
على التقديم الممتاز والرائع. أنا بس في عندي كم استفسار دكتور. أول استفسار، إنه ليه ما فكرت في الديبوت كون المريض أصلا نون كومبليانت، يعني عدة مرات ياخذ يترك أنتي سايكوتيك أز ديبوت، هاي شغلة.
مم.
شغلة ثانية، لما إنه صار رابط سايكلينج أساسا ليش ما توقف الأنتي ديبريسنت؟ والشغلة أخيرة، السوشيال انكزايتي ديسوردر انت حكيت انه تحسنت بينما هو ما التزم على السي بي تي وما كمل كورس اصلا انتي ديبريسنت. فهل ممكن تكون هاي السوشيال فوبيا او الافويدنس اللي عم يصير فيها جزء من البي تي اس دي او لا؟ يعطيك
آه
العافيه.
الله يعافيك. خلينا أبلش بآخر سؤال. هو كمل السي بي تي 12 سيشن أو 13 سيشن تقريبا، والسايكوثيرابيست اللي عملت معه السيشنز، أنا ما كتبتش كل شيء على البرزنتيشن. السايكوثيرابيست اللي عملت معه السيشنز عملت له I think as far as I remember كان um, I think big anxiety inventory I believe. وكان متحسن بالتست هذا وبالسبجكتيف اكسبيرينس. فضل يعني شوي موضوع السوشيال انكزايتي ضل عنده ستيبل لفترة طويلة. والسؤال الثاني ليش ما غيرنا هلا هو دكتور بالأول كان ياخذ سيتالوبرام، بعدين فلوكسيتين، بعدين الانتي ديبريسنتس وير ستوبت. وبعد ما توقفوا الانتي ديبريسنتس ما بتذكر بشهور أو أكثر، صار في عندنا تقريبا سنة صار في عندنا اللي هو الرابid سايكلينج. فبهذيك الفترة ما كان في خلينا نحكي انتي ديبريسنتس توقفت. السؤال الثالث آه, السؤال الثالث ايش كان السؤال الثالث دكتور معلش؟
الديبوت، ليه ما فكرت في الديبوت؟
الديبوت، يس شكرا. الديبوت سوري اني ما كتبت هاي في البرزنتيشن، كنت بدي اذكرها. الديبوت انعرضت عليه مرتين، وموضوع الديبوت هي ريفيوزد، مع انه حكيت له انه اسهل عليك، انه الديبوت ممكن تاخده مره بالشهر، مرتين بالشهر بالكثير، بس فكره الانجكشنز رفضها لانه هو ما بتحمل موضوع الانجكشنز كان.
نعم. أي أسئلة أخرى من الحضور؟ يعني أنا بس بدي أعلق على بيك انكزايتي للسوشيال فوبيا. بيك هو ديبريسيف سكيل وهو سيلف ريتنج. السوشيال انكزايتي لها اذر سكيلز. المفترض في السايكوثيرابي عند بدء حالة من هالنوع ينعمل له personality test، ومتوقع انه لازم يكون عمل له MMBI، وممكن أكثر من نوع من البيرسوناليتي تيست، لأنه يعني psychotherapy is not going just to handle his symptom. Even after full remission of symptom, he may need help in several areas related to his life and relationships and so on. يعني حاليا تخرج وريليفت من الدراسة، بس هلا راح يدخل على الشغل، بعدين راح يدخل على الزواج، بعدين راح يدخل يعني لما نحكي عن مرضى من ببايبولر بنحكي عن life long story and it's reasonable إن إحنا يكون عندنا بيز لاين واضح عن شخصيته وقدراته. يعني بعد فترة طويلة لما حضر أحد من أهله، وواضح لما حضر أخته طلبت بالدخول، ما يعني situation كان far worse than we could think about لما يكون مريض لحاله. In fact أي مريض bipolar or suspected bipolar without family informant, يعني our diagnosis will be very poor، لأنه bilateral information is the standard in this particularly in bipolar. The point also إنه this patient now he's doing well, he's very likely to stop his medication and he will show up in 6 months time in full relapse. This is the scenario. How would you manage him if he comes next summer after disappearing to start all over again?
صراحة بهاي الحالة على الأغلب راح أتواصل مع الأهل and we would probably admit the patient to the hospital. هي أول شغلة. والشغلة الثانية at this time موضوع ال long acting injectables لازم يدخل على المعادلة، ولو إنه البيشنت he does not like needles وما بتحملهمش وإلى آخره بناء على كلام. بس it would be a good choice. حاليا عندنا بالمستشفى fortunately من جديد إجا عندنا الباليبيريدون أو الفيجا سيستينا. ف this would be my option.
Any final comment questions من الحضور كتابة أو كلاما؟ إذا لا معنا نشكرك دكتور قاسم على هذا التقديم الوافي الكبير والذي يعطي فرصة للتعلم والتطوير لنا جميعا. شكرا جزيلا وشكرا للحضور، ولنا لقاءات قادمة إن شاء الله. تصبحون على خير.
صراحة